Welcome to our neurology CME lecture for today. I have the honor and pleasure of introducing Jeff Tsai. Jeff has had I think you accumulated a lot of frequent flyer miles reaching your career. I think started at Duke and then Stanford, then Cornell, and then California, and then back to Colorado, and then to UCSF for fellowship, and finally Seattle. A long journey. He has a background in neurophysiology, the visual system. What can I say about Jeff? He has a very distinguished career and a great scientist. And besides all that, he's also one of the most polite and down-to-earth neurologists I know. So with that introduction.
Okay, well, thank you for inviting me. It's a pleasure to come and talk to you today about management of epilepsy. So I have no disclosures. So at the end of this talk, I hope that you'll be able to develop a plan to manage idiopathic generalized epilepsies, and also to recognize the cognitive and behavioral outcomes in these patients apart from their seizures. So why do we care about this group of patients? Well, they constitute a substantial fraction of all epilepsy cases, about 20 to 40%. They usually are pharmacosensitive, provided that they're diagnosed and treated appropriately. This is a group of epilepsies that generally start early in life. They typically have normal neurological exam, normal intellect. They have normal imaging. They have several different types of seizures that are commonly seen: absence, myoclonic, and generalized tonic-clonic seizures. Because of their normal exam and functioning on the surface, they are presumed to have a genetic basis. And so some of you might know that the term idiopathic has sort of fallen out of favor. Some people take it to mean unknown etiology, which is actually often not the case. So subsequently, people have really come to understand the term idiopathic as synonymous with genetic. But as we learn more about the science and the genomics and neuroimaging behind these epilepsy syndromes, the terminology that we use, which date back to 1989, when the first International League Against Epilepsy came up with this classification scheme, that becomes a little bit outdated. And the league is always constantly trying to keep up with the progress of epilepsy research so that one can communicate about epilepsy in the most precise and accurate manner. So worthwhile to look at the latest incarnation of the proposed epilepsy classification framework. So what we have here is a tiered approach to the classification. So you start with the top and work your way down, and you may only get so far to the extent that you have the information to make that kind of label. So when someone presents with a paroxysmal event, you have to decide whether this is epileptic. And from the clinical information and maybe laboratory information as well, you try to decide what type of seizure it is. And the league also actually has a revised seizure type, which I'll go into in a little bit. But that might be as far as you can get, because that person may only have one seizure. But in most cases, you want to try to make a diagnosis of the type of epilepsy. So is it focal, is it generalized, or is it both generalized and focal? So this is a departure from the previous 2010 framework where they suggested that we do away with the idea of focal and generalized epilepsies and just restrict those terms to seizure types. But they have now reinstated those terms because I think of the feedback that people have pretty good idea of what we mean by generalized and focal epilepsies, and they kind of guide our treatment. But just be aware that focal and generalized are not a clean cut. You know, some epilepsies have both, or maybe even unknown. The next step is to define an epilepsy syndrome. So this is a distinct clinical and EEG pattern that can carry important treatment and prognostic information. So an example of this might be Dravet syndrome, which has that's actually a little bit, that's number 4 actually. So Dravet syndrome is a specific type of epilepsy with a known etiology, in this case a mutation in sodium channel. So that's the highest level of specificity that we can get. In addition, over on the right here are the different potential etiologies that you can consider at all these different levels. And the thing to note is that these are not meant to be mutually exclusive. So you could have a genetic as well as a structural etiology to the epilepsy. And also on the left here, the comorbidities are also a very important aspect of epilepsy that's becoming increasingly recognized, which I'll go into later on in the talk. Okay. What about, so at the very first level, you want to decide based on the clinical or based on the initial manifestation of a seizure, whether it's focal, meaning that it starts within a neural network that's limited to one hemisphere, or is it generalized, involving both hemispheres? The new thing here is that it may be unknown, and this classification allows for that possibility, that is unknown onset. Likewise, like the epilepsy classification, here you can get as specific as you like going down the list. So you can say whether the seizure is motor or non-motor, whether awareness is impacted. And here they've decided that the term dyscognitive is not widely accepted, so they've done away with that. The phrase focal to bilateral tonic-clonic is recommended for what we used to say partial with secondary generalization. Okay. All right. So with that in mind, you know, what would be the suggested terminology for idiopathic generalized epilepsies? So one possibility is to call this a generalized genetic epilepsy. So here the term genetic, which also caused some consternation previously, because people either took it to mean it is inherited or that there's a known genetic mutation. So in fact, you know, we've now come to understand that a lot of the mutations are de novo, so there may not be actually a family history of epilepsy. And also, often the genetic basis is inferred based on family and twin studies, with the underlying mutations actually not known. So that would be one possibility. Or if you actually don't know that there is a genetic basis, you may say generalized epilepsy of unknown etiology. here in the table, I've listed the major types of idiopathic or generalized genetic epilepsy. I'm going to use the terms interchangeably in this talk because to be consistent with the literature. So there are four that differs by the age of onset, the seizure types, and the EEG. And I won't go into them in great detail, but I would point out that there is a newly released teaching tool called epilepsydiagnosis.org, where you can go and you can view videos, you can look at the lead criteria for the diagnoses of various epilepsy syndromes. But these are the entities that I will focus on the rest of the talk. So the hallmark of treatment of generalized epilepsies is medications. So I will go into the evidence-based guidelines for selection of anti-seizure medications. So the International League Against Epilepsy has a guideline that was updated in 2013. From the United Kingdom's the National Institute for Care Excellence, they have guidelines updated in 2012, and the Scottish Intercollegiate Guidelines in 2015. Not to be partial, but I won't go into the American Academy of Neurology guidelines because it's actually more than 10 years old. And so it doesn't really touch upon many, it doesn't have information on a lot of the newer medications. I will cover in more detail some more notable high-quality trials of anti-epileptic drugs in the case of IGE. I'll talk about some new drugs that have come on the market recently and talk about drug selections. Okay. So in reviewing these recommendations, it's important to understand the level of evidence and the level of recommendation and how much confidence you should have in them. The ILAE criteria are actually particularly strict, and I'll go into them in a little more detail. So on the left here in the box here is the rating scale of evidence. So like other class 1, like all class 1 studies, you expect to see a prospective, randomized, double-blinded, controlled trial. The ILAE actually requires a treatment duration of 48 weeks. So that's longer than most other guidelines. It has to meet specific efficacy criteria. Class 2 are like class 1, but the duration is less than 48 weeks, more than 24 weeks. And anything less than that is the class 3. So it could be unblinded. It may be of insufficient duration. If there is an inadequate comparator, that would relegate it down to a class 3. And then class 4 are all the non-randomized prospective, either controlled or uncontrolled studies. So the evidence basically corresponds one-to-one with evidence A, level A, meaning corresponding to class 1 studies, and B to class 2, and so forth. When you get down to level C, you're talking about possibly effective or efficacious treatments. Okay, so what does the league recommend for initial monotherapy for epilepsy? So they've included a few different scenarios, and I've outlined in the box the relevant questions for idiopathic generalized epilepsies. Okay, but here I just really wanted to bring your attention to the fact that there are very few. In fact, there's only one class 1 study for children with absence seizures. There's no other class 1 or 2 studies for generalized epilepsies. This is in contrast to focal epilepsies, where there's much more data for selection of medications. So I'll talk about this particular study a little bit more later. But so that means there's really no level A or level B evidence for selecting any medications, at least according to the lead criteria. So what to do? Well, I guess.
Does it matter? We don't practice like that anyway. I mean, adults with partial onset seizures, it says class 1 is those 4 drugs. But in fact, I would ask most of the people treating epilepsy, we often use lamotrigine, which is only a level C.
Yeah, that's fair. You know, these guidelines are looking at, a lot of times looking at efficacy. So the fact that, you know, you take into consideration the adverse effect profiles and interaction with other medications, I think it's not always reflected in this guideline.
We don't practice like the guidelines.
Right. But yeah, so that's a very good point. But we can look at other guidelines. So this is from the UK, where I think the rigor of their evidence is somewhat less. But you can say that you can look at that for the 2 syndromes with prominent absence seizures. They suggest the first-line agent be either isosuximide, lamotrigine, or valproate. And then for the other type of generalized epilepsies, you know, lamotrigine, levetiracetam, valproate, topiramate are all reasonable first choices. So they suggested that you can offer first-line choice valproate, which is, as Dr. So pointed out, maybe we won't necessarily do at this point. Lamotrigine may be preferred to valproate. If someone has myoclonic seizures, though, lamotrigine may make those seizures worse. Interestingly, you know, most of us wouldn't use carbamazepine or oxcarbazepine as a first-line medication for generalized tonic-clonic seizures, but they can work. And then in terms of adjunctive treatments, these are the agents that you've seen before. With the caveat again that some of the sodium channel and other drugs can exacerbate myoclonic seizures. So I put this up because I think this guideline actually reflects pretty well what we do in fact practice as epileptologists. So in genetic or generalized epilepsies, people recognize that valproate often is the most effective medication. But when it is poorly tolerated or otherwise contraindicated, we often use lamotrigine or topiramate. And this is particularly true in women of childbearing age because valproate has been shown to increase the risk of malformation in a fetus up to 20%, and also caused significant neuropsychological side effects once the child is born. And so in those cases, levetiracetam or lamotrigine may be preferable. Isosuximide is shown to be efficacious and has lower side effect profile than valproate for absence epilepsy. And I think this last one is important, that the adverse effect and interaction should also direct the choice of medications. So let's look at a little bit more closely the only class 1 study for idiopathic generalized epilepsy. So this study is a comparison of the efficacy, the tolerability, and the neuropsychological impact of 3 medications in newly diagnosed childhood absence epilepsy. So it meets class 1 criteria in that it's multi-center, it's randomized, it's got a large cohort. They evaluate both clinically and using EEG during the enrollment and the trial period to ascertain whether the patient is having seizures. So the primary outcome is freedom from treatment failure at 16 or 20 weeks. Or if the subject had a generalized tonic-clonic seizure at any time or had to withdraw due to adverse effects at any time. In addition, they had the foresight to also consider neuropsychological profile. So specifically, they looked at the attention performance of these patients. And I'll get into that in a little bit. But this allows them to separate 2 medications that turn out to have fairly similar efficacy. And it turns out that valproate actually causes significant decrease in attention function in 49% of the cohort versus 33% in ethosuximide. And so as a result of this study, ethosuximide is recommended as the initial monotherapy for childhood absence seizure. So here, this is the primary outcome data. So in the weeks since the randomization, plotted against the freedom from treatment failure. So what you see is that lamotrigine is not as efficacious as the other 2, and this is apparent by week 20. There's a follow-up to this study. So at 12 months, the patients are still double-blinded control at this point. So the primary outcome that you saw earlier continues at 1 year. So the green line is the lamotrigine, and it's clearly worse than the other 2. 42% of the failure due to adverse effects is in the valproate arm. Okay, and then 2/3 of the failure due to seizures is in the lamotrigine arm. So it's saying that the valproate is causing more adverse effects, but it is more effective. But just another thing to point out is that even valproate has only 50% has a 50% treatment failure rate. So for a syndrome that's often thought to be benign, it's not, maybe not as benign as we thought. Okay, so this is another large study which sought to compare the efficacy of 3 medications that are thought to be broad spectrum and often used in generalized epilepsies: lamotrigine, valproate, and topiramate. It's got a large sample size. The trouble with this study is that they actually enrolled a large number of focal or unclassified epilepsy. So, and it's open label, so that makes the study class 3 by ILA criteria. But in the IgE subgroup, valproate was better tolerated than topiramate and lamotrigine. And that is seen by, so this is the probability of continuing on medication. So valproate in blue here is better than topiramate and lamotrigine. And then for the probability of achieving remission, 12 months remission, valproate and topiramate are comparable and superior to lamotrigine. And so the result of this, conclusion of this study is that valproate remains the drug of choice for many patients with generalized epilepsy. But with the caveat that I alluded to, that its potential adverse effects on pregnancy should be considered. So perampanel is a new medication that's first-in-class medication. It's a non-competitive antagonist of the AMPA glutamate receptor, which mediates most of the fast excitatory transmissions in the CNS. It's been previously approved and shown to be effective for focal epilepsies. But there's a recent study that demonstrated it's also effective for resistant primary generalized tonic-clonic seizures as an adjunct treatment. This study is notable for its careful selection of patients. And the primary outcome is the % change in primary generalized tonic-clonic seizures in 28 days. So perampanel results in a 76% reduction in seizures compared to 38% placebo, which is significant. Seizure freedom rate is 30% versus 12% in placebo. So this seems promising, and it's certainly a welcome addition to our tools for treating primary generalized tonic-clonic seizures. But there is a downside, and that's a FDA issued a black box warning that this can cause severe neuropsychiatric reactions, aggression, anger, irritability. So this is likely dose dependent. So I think if you use that carefully, it may be a useful agent. I would say a lot of us really haven't had a whole lot of experience using this to treat primary generalized epilepsies yet. So a slightly less new medication is lacosamide, and there's not a whole lot of data. There's just a few case series that suggest some benefit in myoclonic and generalized tonic-clonic seizures in IgE. So something else to think about. Judicious selection of anti-seizure medications is warranted. So the data here are all class 4 evidence. But there are multiple studies that suggest that absence and myoclonic seizures may be aggravated by some anti-epileptic drugs. And this causes so-called pseudo-intractability in some of these patients. And so these medications would be sodium channel agents such as carbamazepine, oxcarbazepine, phenytoin, which can worsen absence seizures, tiagabine and vigabatrin also. The main thing that we worry about are absence and myoclonic seizures, which can be affected by these medications. Carbamazepine can actually cause absence status. It's been reported. I do point out that some of these same medications actually can work for the generalized tonic-clonic seizures in these epilepsy patients. And the cause for this is really it's not quite clear, but it's presumed to be due to some underlying pharmacodynamic interaction that we don't expect. All right, so with that in mind, I wanted to just bring up pharmacoresistance in IgE. So 80 to 90% of these patients are thought to be pharmacosensitive. And so maybe for that reason, there's just not as much data for generalized epilepsy compared to focal epilepsies that you've seen earlier. But that actually still leaves about 10 to 15% of the patients who truly are refractory, and not because of poor selection of medication or lifestyle problems. So in this particular series, they followed 155 patients with juvenile myoclonic epilepsies for a number of years, and 15% proved to be resistant despite adequate treatment. They found that psychiatric comorbidity and having multiple seizure types are a risk factor for pharmacoresistance. So what do we do for these patients? Well, so vagus nerve stimulation is one possibility. The 2013 practice parameter on vagus nerve actually did not specifically address this particular group of patients. And the earlier report really focused mostly on focal epilepsies. There are some class 4 studies listed here that suggest efficacy for vagal nerve stimulation in IgE to a degree that's roughly comparable to that seen in focal epilepsy. So about 50% responder rate, somewhere around 50%, and overall reduction in seizures in the same ballpark. Limitations of these studies is that medications were also adjusted at the same time, so there's that confound. And there are uncontrolled and unblinded studies. Another approach is dietary. So modified Atkins diet has been used for about 10 years now, and it's been shown to have some efficacy in drug-resistant epilepsy patients. This is pooling over 10 years, about 400 children and adults in multiple studies, and about half of them have a 50% responder rate. There's less data for the idiopathic generalized epilepsies. So there's one case series of 8 people that's followed for a short term, and with some decrease in seizures. The limitation of modified Atkins diet is that of these studies is that they're all pretty short follow-up, and they don't always have EEG evidence of improvement in seizure control. The issues with modified Atkins diet is potentially that it's not easily tolerable, and the chance of seizure freedom is not very high, and so actually very low. So a lot of people may not want to put in the effort to stay on this diet for that reason. It is more tolerated than ketogenic diet because it does not require initial fasting or inpatient admissions. It does not require caloric and fluid restrictions. So it's another possibility. Okay, well, moving on to the next part of the talk, where I want to cover the outcome of these patients. So first of all, talking about seizure control. So I mentioned before that childhood absence is usually thought to be a benign entity in which the kids usually outgrow their epilepsy. So there are a few studies here that follow these patients over time, and about 60 to 90% actually achieve terminal remission. So they're seizure-free without medications. The mean age at remission is about 4 years after onset, so about 10 years of age. But that's a proportion of them do evolve into juvenile myoclonic epilepsy. And the negative factors include having myoclonic seizures, abnormal EEG background, prolonged seizures, and family history of seizures, and poor treatment response initially. So this is another syndrome where they only experience generalized tonic seizures. So in this group, the mean age of onset is 6.7 years, and they're followed for 22 years. They have normal IQ, and 75% achieved terminal remission. So overall, from the perspective of seizure control, these two groups do pretty well. Juvenile absence epilepsy. Again, coming from these two particular studies, about 40 to 60% become seizure-free. These are either at last follow-up or they've been seizure-free for 2 years. Those people that without generalized tonic-clonic seizures tend to do better. And 20% do evolve into juvenile myoclonic epilepsy. So maybe not quite as good. Only about half achieve seizure freedom. So for JME, there are cohorts that have been followed for up to 50 years, and despite what most people think that these patients require lifelong treatment, about 8 to 25% do achieve terminal remission. The poor predictors are what you see there, having absence seizures, GTCs preceded by bilateral myoclonus, and polytherapy, poor response to treatment. So this particular entity is actually sensitive to lifestyle. So some of these patients may be pseudo-intractable in that they don't make sure they get enough sleep, or they don't avoid alcohol. So that's something to be aware of. So in addition to seizures, what about the cognitive and behavioral outcomes. In childhood absence epilepsy, this is data from that randomized controlled trial that they showed you earlier. So they did a very nice thing, very interesting study in which they measured their neuropsychological function at baseline prior to treatment. And so 36% of these kids had impaired attention. So you say, well, that's not surprising because they're having seizures. But with treatment, 49% of the children on valproate continue to have persistent attention deficit, despite despite some of these patients who have EEG documented control of their seizures continue to show the attention deficit. So this attention problem is not simply due to their frequent absence or to medications. So suggesting that there is something underlying their disease that's really also causing neuropsychological impairment. So valproate fared worse than isotretinoin and lamotrigine in this regard. In another study here, these kids who have absence epilepsy are more likely to have anxiety and depression. And the degree of this is not correlated with their medication, their intractability of their seizures. Again, pointing to the fact that there might be something underlying, there's some underlying biology that independently contributes to cognitive deficits. So when Dr. Jantz first characterized juvenile myoclonic epilepsy, he reported this JME personality anecdotally, that they seem to have more social immaturity, disinhibition, and lack of endurance, kind of like the frontal lobe patients. Later on, people have actually formally measured these effects, and shown that indeed JME patients do have decreased verbal fluency, have less mental flexibility on card sorting tasks. They have worse working memory. And moreover, in family members of these patients who are otherwise asymptomatic, they also manifest some of these similar cognitive dysfunctions. So this is just all to point out that I think it's important to be aware of the cognitive and behavioral outcomes in these patients, particularly in kids and young adults who are still, developing, and to make sure that they be assessed for these in these areas and be treated as necessary to help them learn and grow in society. Okay. So to summarize, making a diagnosis of the epilepsy syndrome can provide helpful prognostic and treatment information. I think that the adverse effect and drug interaction should have a big role in determining the choice of medications for individual patients. Some of the newer drugs can be effective. Consider vagus nerve stimulation, and diet for the refractory cases. The comorbidities of epilepsy in some of these cases may actually outweigh the seizures themselves. And so, example here would be the childhood absence epilepsy patients who are seizure-free but continue to experience attention impairment. So these patients should be assessed for cognitive and behavioral comorbidities as well. All right, so let's see if we can put what you just heard into practice. So there's this 41-year-old woman whose seizures began at 18 years of age. She has two types of seizures, primary generalized tonic-clonic seizures and staring spells, where she would be unresponsive for a few seconds to a few minutes without posictal state. She has fairly frequent seizures, generalized tonic-clonic 2 to 4 per month. The staring spell maybe 1 to 2 per day in the past. A little bit unclear how often she's having them now. She has family history of epilepsy. Her exam is normal. She has essentially a normal neuropsychological profile, or I should say normal cognitive function, but does have a history of bipolar disorder, attention deficit, anxiety. She used to work. Let's see, her EEG demonstrates bilateral 3 to 6 hertz spike wave discharges, maximal over the frontal central region. And her MRI is essentially normal. So she's had epilepsy for more than 20 years now, and she's tried many different medications. The phenytoin seems to be the one that helped her the most, actually, but did not make her seizure-free. You see the rest of the medication that she's tried. Levetiracetam caused depression and psychosis. Topiramate was ineffective. Depakote was ineffective. She could not tolerate lamotrigine very well. So she ended up getting a vagus nerve stimulator, which helped decrease the seizure frequency, duration, but not the frequency. So currently she's taking 3 medications in addition to the vagus nerve stimulator. So what do you think would be the diagnosis here, and what would you do next? Well, does she have a, well, okay. Well, this is a talk about idiopathic generalized epilepsy, so she has that diagnosis. I think you can, from the fact that she has a family history, you could safely call this a generalized genetic epilepsy. I think she actually fits the criteria for juvenile absence epilepsy very well. What about next steps?
For a child with absence, ethosuximide would be a consideration if the staring spells were the primary issue, but it wouldn't treat the myoclonic generalized episodes. Right. I'm not sure how well it works with juvenile absence. The other consideration could be lacosamide.
Yeah, she actually is not reporting. She doesn't report any myoclonic seizures, and it's unclear whether she's having a lot of absence at this point or not. She's not very keen on coming in for long-term monitoring, but she's clearly having still frequent generalized tonic-clonic seizures. So lacosamide may be an option. I would be a little bit leery about perampanel for her, given her history, psych history. Yeah, so I'm actually going to start her on modified Atkins diet to see if that would help a bit. It's not going to make her seizure-free. Another possibility might be just to increase the phenytoin, which has helped her in the past. And for her tonic-clonic seizures, that I think that might be that's sort of the main concern that I have at this point. Try to get that under control. Okay, great. Thank you for your attention.